Hello and welcome to this video. My name is Dr. Lasker. I am a consultant radiologist and I have teamed up with Collective Minds Radiology to try and bring some really state-of-the-art teaching to you. So what you should be able to do is watch this video and actually go through the case that I talk about in this video. The set of cases that I'm going through are going to be things to do with emergency imaging, things that happen when you're sitting in the ER or the A&E or wherever part of the world that you may be from where emergency scans happen. And I'm going to introduce a few principles and get you guys to try and understand how you can actually use basic principles, the things that you do know, and figure out the things that you don't know. And also just understand a few scans and hopefully see a few interesting things. So without much further ado, let's go straight to it. Okay, let's go through this first case. So let's get through some basic anatomy first. So what we're looking at is the abdomen and pelvis scan. This is a CT study, and we can see the lung bases that are sitting over here and the lung bases that are sitting over here. That's very, very black because it's full of air. And if you look at the air outside the body, it's also very, very black, which basically means that there is air within the lungs, which is completely normal. But if you've got air that belongs, which is found to be seen anywhere else, then you've got to start wondering whether the air should have been there in the first place. And we're going to get to that as we go through this case. Then we've got the heart that is sitting right over here, and we've actually got just a bit of the dome of the liver over there. Sitting over here is very, very white looking stuff. That is actually the bones. This is the spine, these are the ribs, and that is what calcium looks like on a CT scan. So if you've got that density sitting anywhere else, then you have to start thinking of the possibility of there being a calcification somewhere that it shouldn't really be. Now, as we scroll from the very, very top and come down, we can start to see the liver. This is the liver that is sitting over here. And the other thing to take into consideration is the position of the patient on the study. You can see that the bed of the scanner is actually sitting anterior to the abdomen of the patient. If the bed is anterior to the abdomen of the patient, therefore that must mean that the patient is lying on their front. What scan is it when you've got someone who's lying on their front? It's a CT-KB. So this is a scan looking specifically for renal calculi. This is not really to look for anything else. In this particular situation, I think they've said that this patient's got left-sided abdominal pain. But before we start to really hone in on what the possibilities for the cause of pain may be, and yes, they may be calculi or a renal stone, we're going to go through some of the anatomy. So as we scroll further down, we can start to see that the liver is sitting right up here in the right upper abdomen. If you ever get confused as to which side is the right and which side is the left, try this little silly thing that I use, Ralph Lauren. When you write that Ralph Lauren, RL, therefore this is on the right and this is on the left. Okay, it's really silly, but that's just the way my mind works. And as we scroll down, the thing that could be causing upper abdominal pain or any sort of abdominal pain is the gallbladder. The gallbladder is this thing sitting over here. This spherical teardrop structure that is sitting over here is known as the gallbladder. Now, the thing about this gallbladder, it looks very thin-walled, and there doesn't seem to be any fat stranding around the gallbladder. Now, look at the subcutaneous fat. Everyone's got a bit of fat under their skin. It doesn't matter how often you go to the gym. Now, inside the abdomen, there's also some fat, but if it looks very sort of similar to the subcutaneous fat, then you're looking at normal fat. But if it starts to get hazy, cloudy, that's when you've got to start to worry that there is some sort of inflammatory process that is going on. I will show you what the inflammatory process may look like, but in this particular situation, the gallbladder looks completely normal. Now, what's the other thing that could be causing abdominal pain? It's the pancreas, right? Pancreatitis. So the pancreas is a sort of fluffy, leaf-like structure sitting within the upper abdomen, and that actually looks completely normal. And again, all around it, all that fat around it looks completely black. It doesn't look like there's any abnormalities there. Okay, so the pancreas looks normal. Now let's look at the kidneys. So the kidneys is this structure over here and this structure over here. And as we scroll down this kidney, you'll start to notice that there is these hyperdense focuses or foci located within the liver. There's been a few in this one. Can you see that hyperdense dot? And then remember what we said, if it's hyperdense and white looking a little bit like bone, then it's most likely to be calcifications. And actually most renal calcifications, renal stones are going to be calcified and therefore are going to be very bright on the CT. And in fact, on the left side, you will see, if you keep your eyes there, you'll see a few calculi sitting within there. Now, renal calculi sitting within the kidneys does not actually cause any pain. It's when they actually dislodge and then go down the ureters, that tube that goes all the way down to the urinary bladder. If it gets stuck down there, then you start to have a lot of pain. and it also starts to cause blockages of the kidneys, and you also get that fat stranding that I was talking about earlier. But these kidneys look normal, and I guess you just have to take my word for it on this particular video. The ureters are completely normal as well. So running out of things that could be causing upper abdominal pain, think about things that are common. So now we have to go through the bowel, literally chase through the bowel. Going through the bowel means that you go right down to the rectum, which is over here, and you follow the bowel. And now you're going to maybe hear my mouse scroll away as we go through this. So if we start from the rectum and then work our way up, and we're going to hear my mouse scroll away, we keep coming, and we can see that the bowel, sigmoid colon, rectum, sigmoid colon bends this way, goes anteriorly, goes this way, this way. And you really got to keep your eyes focused on the prize. You really got to try and see where you're going. And now you can see there's this black stuff. The black stuff again was air, and that is sitting within the bowel. And it can be difficult to really know where the bowel is going. So what I'd recommend is using a different window to try and see where the bowel actually connects to. And it appears to be connecting to this region here, and then looking like it comes back downwards and then back around this way. It's a bit difficult to follow this bowel, but then you start to see this area of bowel. Remember the fat stranding I was talking about? That is fat, and that is fat as well, but that fat looks very, very cloudy and is located within the left iliac fossa. And as you look at it, you can see that it curves around this way and then back up this way. But this entire segment here has got lots of fat stranding around it. That basically means there's inflammation. Now let's just follow the rest of the bowel. A few of the constants with regards to the bowel, because a lot of the bowel can move all over the place, is that the descending colon and the ascending colon are pretty much in constant places. So if you find yourself finding it difficult to know where the bowel is, just go for the ascending colon, the descending colon, to try and reset your eyes if you're not going to be able to reset yourself from the rectum. And again, look, we can follow the bowel up, follow the bowel up, it's over here, keep following, and we're going to come up to the splenic flexure. That's the spleen, splenic flexure. Then we've got the transverse colon, transverse meaning it's going right across the front. You can see my mouse, we're following, going this way, going right across the front like this, see there like this, and then going across. Now we're at the ascending colon, you come all the way down to the cecal pole and right to the very end. Now, the thing to try and distinguish is the cecal pole and the ileocecal valve. Now the ileocecal valve is like a pair of lips. I'm going to try and draw the lips that I'm talking about. And what you'll find is that there is a fatty lip sitting within the region of the cecal pole. That is fat, and within this region you can see some focal fat sitting there. You can't convince yourself right there. Just keep your eyes there and just have a look right there. That is the ileocecal valve, and coming out of there you'll see another tubular-like structure, and that is the terminal ileum. But in this situation we have noticed that there is actually in fact some inflamed bowel located within the left iliac fossa. Not many causes of pain located in the left iliac fossa beyond the possibility of being a calculus, but there's also the possibility of diverticulitis, and this patient has actually got diverticulitis. So for the average Joe, that could be the end of the question, let's move on. But actually you've got to look and see whether there's any other secondary findings of diverticulitis. For example, this patient may have a collection as a result of a perforation. We can't see much of a perforation, but do we see any air within the abdomen, which would suggest that this patient has had a perforation? So coming up, you've got to start looking for air within the abdomen. By definition, air within the abdomen is going to be indicative of a perforation of a intra-abdominal solid viscous. So the best thing to do is to go to lung windows. Those are the lung windows, and as you can see, there is the lung parenchyma, and all the air within it is very, very black. And as you come down, you can see the diaphragm sitting over here, and then beneath the diaphragm there's evidence of the same black-like density sitting beneath there. And as you kind of scroll through, you see a little bit there, a little bit there. You can see a few locules of air sitting just around the spleen over here, a few locules of air sitting over here as well. And as you come further down, look, just beneath the hemidiaphragms, adjacent to the spleen, which is sitting over here, you've got some air as well. So this patient has clearly got some intra-abdominal free air, multiple locules of intra-abdominal free air. And the more you kind of scroll through, the more you see another dot there, another dot there, another dot there, another dot there. There's just so many dots of air located within the abdomen. So this is basically an acute diverticulitis that has perforated, and there's resultant air within the abdomen. And so what we've done is go through the basic anatomy, the solid organs. We've compared those densities with the densities that we know, such as air, bone, soft tissue, and then identify the pathology, which was diverticulitis. Our next case. So this is a slightly different looking study. This actually has some contrast within the body. When you actually remember looking at the previous study, you couldn't really see the aorta, you couldn't really see the appearance of the heart all that well, and as you kind of go through the scan, you can see the vessels quite nicely. They look very, very bright, very, very bright kidneys. You can actually see the parenchyma of the kidneys really, really well on this study. So this is a contrast study. Again, different from the last study, you can actually see that the table is sitting behind the patient, not in front of the patient. So this patient is lying on their back. Right, so now we've got those things out of the way, let's try and find the aorta. So the aorta is sitting right over here. That's a big trunk-like structure coming from the thorax. This is the thoracic aorta, and as you follow down, this will go and continue into the abdominal aorta. So to the right of that is going to be the IVC. Now let's say you had this area only and you weren't sure which one is which. Make sure that you know that the aorta is always on the left. Aorta is on the left, the IVC is on the right. Now in this particular phase of imaging, what you can see here is that the aorta, it looks kind of bright, but not quite as bright as the adjacent bone on this particular window. So this is unlikely to be an aortic phase image. This is not an aortic phase image. And actually, when you look at the portal vein, which is this structure sitting over here, which goes into the liver, that actually looks brighter than the aorta. So this is a study that is actually geared towards the portovenous system, and therefore is known as a delayed phase or portovenous phase study. So kind of gleaned a fair bit of information just from the initial few slices. Again, this patient has got abdominal pain. Let's have a look at the structures that will be causing abdominal pain from moving on from our previous video. So as you scroll through, what you may have noticed that there is this high density material sitting within here. Now, like I said on the previous scan, this may actually be calcification, but it kind of looks a bit more shiny, a lot brighter than the bone that is over here. So what we can do is go to the bone windows and actually see that is very, very linear and very, very bright. Not many things can be so linear and so bright other than surgical clips. So this patient has likely have had previous gallbladder surgery, and this structure here that you may have thought was actually the gallbladder is not. It's actually the CBD, which actually can get a little bit dilated once you've had a gallbladder removed. In this area you don't really see much going on, and the liver actually looks okay as well. Now, what else could be causing abdominal pain? The pancreas. So you can see this leaf-like structure sitting in the upper abdomen, and it doesn't look like there's very much fat stranding. Remember what I showed you with regards to fat stranding? The fat actually looks okay. It doesn't look like there's anything abnormal going on. Next thing could be the kidneys. The kidneys look very, very bright, but the actual kidney parenchyma looks okay and no evidence of any fat stranding. Let's scroll through to be sure. So let's look at that right kidney. Keep your eyes on that right kidney. That all looks okay. Let's come to this side. And the left kidney looks okay as well. No fat stranding around the kidney whatsoever. So running out of options for what's causing this patient's pain. Don't worry, we're going to figure this out. So let's go from the very, very bottom, quite literally. Let's go from the very, very bottom, quite literally, work our way up, work our way up, work our way up. And we can see that the sigmoid colon starts around here, and we start to veer off around this region. That's the bowel. Let's keep following, and it kind of curls around this way, and then we keep going. Where is it going? Like this, right around like this, and then kind of curls across to this way. And I think we're going to be coming up to one of our constants, the descending colon. That's the descending colon. Let's come up, come up. Mouse is still right here. Keep your eyes right over here. And now we'll come up to the spleen that is sitting over here, and that is the splenic flexure. Now let's work our way across the front. There you go. You can see the transverse colon going right across the front like this, right across the front like this. And then we are going across to the hepatic flexure. So that's the bowel over here, hepatic flexure, and this is your other constant. The ascending colon is going this way, this way, this way, this way, this way. And as you come up to about this region, you start to feel as though there may be something else going on. You can start to see, instead of sitting within this region, the cecal pole has moved sort of centrally. See that? It kind of goes this way, and then veers off centrally, keeps coming down, keeps coming down, keeps coming down. So the cecal pole is sitting within this region over here. Now, remember what I said about the ileocecal valve? We're looking for a fat-like lips or fatty lips, and you can see there is some fat-looking density sitting within the cecal pole. So that's going to be the ileocecal valve, and you can actually see a small segment of the terminal ileum sitting within that region. So that all looks okay, but now we should kind of follow a bit further down. And as you come further down from the cecal pole, look, cecal pole coming down, coming down, coming down, coming down. Let's go the other way, or the other down, coming down. So the cecal pole coming further down, further down, further down. And you start to see another tubular structure curling around this way and coming off. And this structure doesn't seem to go anywhere else and is coming off the tip of the cecal pole. On top of that, you can actually see that there it looks a bit cloudy around it. So that's the fat over here, and the fat over here looks very, very cloudy. This is actually the appendix. This is therefore appendicitis, and this is going to be what's causing the patient's pain. This is the appendix, looks very, very big and almost finger-like, curling within the mid-lower abdomen, which is kind of unusual with regards to where it actually is. And then on top of that, we've got to start thinking about whether there is a perforation, and we would go through using the lung windows to look for whether there's any air where it shouldn't be. In this particular situation, there is no air where it shouldn't be, so therefore this is no perforation. And actually, when you looked at the appendix itself, there was no evidence of any collection either. So this is a really great case of appendicitis with no perforation, no collection, in a slightly odd position located with a central lower pelvis rather than being within the right iliac fossa as you would otherwise expect. So what we've done is basically use the basic principles of following the bowel all the way through to the cecal pole, which can be difficult in some circumstances, and therefore find the appendix, which itself was inflamed, suggesting that this is actually appendicitis. Okay, so we're on to the next case. Again, you can see this is a contrast study. You can actually see the structures of the heart, and as you come further down, you can actually see the vessels of the liver, and you can see the kidneys actually look okay as well. Let's try and identify the aorta. The aorta is the thoracic aorta, and as you scroll down, you should be able to follow that aorta all the way down into the abdomen and pelvis. Now let's have a look at the portal vein in comparison to the aorta. Now the portal vein, which is sitting over here within the liver, looks slightly brighter than the aorta, so this is going to be a portovenous phase image. So again, abdominal pain. Let's try and see what is going on here. So gallbladder wise, that's a bit difficult to see, but it is sitting within that region over here. I'll try and draw it out for you. It's this thing over here. That is a gallbladder, and actually again it looks completely normal. There's no evidence of any fat stranding within that region. Okay, fine. So let's have a look at the pancreas. Let's look at the pancreas. What's the pancreas looking like? And the pancreas is leaf-like structure sitting down the middle of the abdomen, and there doesn't seem to be any fat stranding within this region either. That looks completely normal as well. Okay, so pancreas is normal. There's not pancreatitis. Let's have a look at the kidneys. This is the right kidney, this is the left. Remember, Ralph Lauren, right, left. And you come down, you come down, you come down. And actually that kidney looks pretty normal. And you come up this way, have a look. This looks completely normal as well. We're kind of scrolling. It all looks completely normal. So we're gonna have to do what we did before. Follow the bowel. So you may have noticed that the bowel is this stuff over here. What's sitting inside the bowel? This is air. Air outside the body, air within the body. So this is air, and it looks like there's a lot of air inside this bowel, doesn't it? It does look very, very weird as you start to go through it, but let's stick to basic principles and start from the very, very bottom. So as we scroll up from the bottom, I'm going to start using my mouse wheel now. You can see that this is the sigmoid colon. I'm going forward, trying to follow it, and then you can see it connects to this region over here, and then things start to look a little bit dilated. You can almost see like a fluid level, like a linear line going right along the top. So there's been some stasis of a bit of fluid within what appears to be the rectum or the rectosigmoid junction, and the bowel just looks really distended as you come further up. This is the bowel over here. So there's not really much more to say beyond the fact that you can see that this bowel looks very distended, going this way, back round, and you think this could be the transverse colon, but actually if you follow this area, it goes back down into the pelvis before it extends and it joins into the ascending colon. So something clearly isn't right here. So the general rule for what I would say in this particular situation is try different windows if you're not entirely sure what's happening. So let's get to the different windows and just get everything into view. So this is the not sagittal, coronal images. So let's look at the coronal images, and as you scroll through from front to back, you might get the answer when we are coming up to about this region over here. So for those of you that are quite well versed in plain films, if I go to the lung windows, it starts to look like there is a coffee bean this is probably one of the best coffee beans you'll ever see. So this is actually looking a lot like this could be sigmoid volvulus. Now the real giveaway is if you scroll through this abdomen, you'll see like a twisting of the bowel, and you'll see exactly what I mean. It'll be like a real whirlwind, a whirlpool. It's called a whirlpool sign. So if you haven't seen it, I want you to keep your eyes in this area here as I scroll through, and keep your eyes there, keep your eyes there. I'm going to show you again. Keep your eyes there. Can you see this little dot? Now if I scroll through, it twists around and then becomes large. Twist around the other way, you can see all these vessels. See all these mesenteric vessels? They're all swirling around that particular area over here. So this is known as a whirlpool sign, pretty indicative of a sigmoid volvulus, and that's also been proven by the very apparent coffee bean appearance. So this is sigmoid volvulus. This patient will probably need to have surgical input as soon as possible. So we identified the dilated large bowel, not small bowel, and then we're able to identify the swirl sign on the coronal images, which basically means that this is sigmoid volvulus. Okay, let's go for this particular case. Again, we've got a contrast study. You can see there's contrast within the heart, and in this particular situation you can see this oval-like structure sitting within the upper or lower chest or upper abdomen, and you've got this very sort of dense spherical line that is sitting over here. What could that be? You follow that dense line, keep coming down, looks very tubular. That's the NG tube sitting within the stomach. Therefore this is a hiatal hernia sitting adjacent to the aorta that is over here. So now you know where the aorta is, you know this is a contrast study from what we've seen before. Let's follow the bowel, let's follow the rest of the scan. So if you go to the rest of the scan, we're looking at the gallbladder, and the gallbladder is sitting within this region in the context of abdominal pain. And actually you can see that there's a bit of fluid around it, and actually the gallbladder looks slightly hyper enhancing. It looks like there's a dense line around it, and it looks very, very shriveled up, so that doesn't look quite right. And then if you look at the biliary tree, you can actually see there is some air within the biliary tree, so there's air within the intrahepatic ducts. So something's not quite right. This patient may have had a previous cholecystectomy. They may therefore have air within the biliary tree, but I'm telling you now, this patient has not had a cholecystectomy. So something is clearly abnormal within this region. So using our method, we've already discovered something is very, very abnormal with regards to the gallbladder. Now coming further down, as we look at that gallbladder, try and inspect it a little bit more, you can see that there is a defect on that medial aspect of the gallbladder. I'm going to draw that out for you. So if you draw a line like so, and then you can see the gallbladder, and then you can see sort of a defect like this, and then it kind of opens up into whatever this is. So what is that structure? If you follow that up and down, that is actually the duodenum. Look, remember the stomach we're talking about sitting over here? Let's find that NG tube, follow this way, follow this way, follow this way, and then you're going to come into sort of D1 portion of the duodenum, and look at that. There is a definite defect located between the gallbladder and the duodenum. So that kind of raises alarm bells. Something has communicated between these two structures, and what's happened is that air has gone into the gallbladder and therefore into the biliary tree, which is what we're seeing. So let's try and focus on what's going on, and as we scroll down you might be able to notice that there are multiple loops of dilated small bowel. The small bowel is this stuff over here. I'm going to draw it out for you. So that is small bowel. Small bowel kind of looks a little bit more rigid, like a caterpillar, and sometimes you'll see lines going right across the front known as valvular coniventes, and as you can see valvular coniventes going right across. So this is small bowel. Clearly small bowel is far too large. Small bowel should not look like that. It should be very, very collapsed. So the small bowel doesn't look normal whatsoever, and you can see more small bowel located within the lower abdomen. So again, we've kind of gone through one thing to the next thing. We've noticed that the small bowel doesn't look quite right. What could have happened? And as you scroll through the small bowel, you hopefully would have noticed that there is these dense structures sitting within the left lower abdomen over here. Now if I go to the bone windows, you can see they're very spherical, they look lamellated, they've got sort of a dense outer calcification. There's multiple of these sitting within the bowel wall over here, and actually everything sort of proximal to that area looks very, very dilated, like dilated bowel. So this is definitely small bowel because it kind of communicates with more small bowel as you go up. So and these spherical structures are actually gallstones. So what's happened here is that this patient had multiple gallstones sitting within their gallbladder. They've eroded through into the duodenum and then carried on all the way through the small bowel and then finally lodged up in the left lower area over here, resulting in sort of what is known as a gallstone ileus. So a few learning points here. We've kind of used our method of using gallbladder first and then found out there was an abnormality, and we were able to identify that defect with the duodenum. We're able to identify what is dilated small bowel by the valvula convergentes, and then subsequently identify partially calcified gallstones located within the left iliac fossa. So a really interesting case, lots of great learning points. So in this case, we identified dilated small bowel, traced them all the way down to gallstones located within the left lower abdomen, and therefore found the defect within the gallbladder, which would suggest that this is overall gallstone ileus. So thank you for watching those cases. Hopefully it was useful. We went through some really great things. We saw some non-contrast studies, some contrast studies, a few emergency things, diverticulitis, appendicitis, stones. We saw all sorts of great things, and I hopefully will be able to do some more lectures for you guys soon. So thank you for watching, and hopefully see you soon.